All right, I'm gonna do something a little bit different this time. We're gonna do what's called I call like a clinical reasoning session, and this one will be on edema. So I'm gonna start doing these more frequently. Basically, they're gonna be based on cases I have been a part of at some point throughout my medical career, or cases I found online that patients were willing to share, or doctors were willing to share. Never will have any names or MRNs or no way to track back to a patient, or I'll just come up with cases, as I often do. But I think these will be able to kind of help you guys clinically think through very complex problems. So I'm never going to pick like just a straightforward case. The answer at the end may be straightforward, but it may not present straightforward. Um, and it'll help you kind of develop your critical reasoning skills, and you'll kind of see how I worked through it, either if this was like one of my patients at some point, or if I, come up with the case myself, how I would work through it, if a patient presented like that. So I think it'll help you in multiple ways. So I would suggest, like, as we go through, try to come up with the questions I'm asking you, try to come up with your answers. So pause your screen and we'll work through them. So I think these will be pretty helpful. So we'll work through a real life. This one will be based off of a real life case I saw at some point during my medical time during school, and then we'll go through from there. So really brief. Our patient, 33-year-old female, from Southeast Wisconsin. They came to the emergency department with swelling and then chest pain. So that's all we know. Okay. So in the ED, the vitals, temperature was good, heart rate good, BP good, respiratory rate good, SpO2 100%. So vitals hemodynamically stable. In the ED, wow, her BNP very elevated, 814. So that's quite high. Her troponin 6 and 6. So we got 6 right off the bat, right? And then at 2 hours later, 6 again. So stable, unchanging, not worried. Okay, because they had the chest pain, right? Probably want to get troponins. Okay, probably want to get troponins and an EKG right off the bat. Um, she went to urgent care the day before, and here were some of her labs from the urgent care. Her creatinine was 0.49. That's actually a little bit low. BUN was 5, a little bit low. AST, ALT normal, T-Billy normal, TSH within reference range, hemoglobin a little bit low, platelets normal, white blood cell count normal, ESR and CRP normal, pregnancy test normal. Her UA was unrevealing, Lyme disease normal or negative. The patient received Benadryl and steroids at the urgent care, and it did not make things better. Okay. In the ED, they got imaging. They got bilateral ultrasound venous duplex, and was negative for deep vein thrombosis in both legs. They also got a chest X-ray that didn't show anything. Okay, it was just read as completely normal. I took a look at the chest X-ray, didn't see anything as well. Um, so okay, the patient came in with chest pain. We got troponins, but let's get an EKG, right? That's when I see a patient who has swelling and chest pain. First thing I'm going to probably do is get an EKG and troponins, and then we'll also go down the pulmonary embolism pathway, right? So that's why the patient got the deep vein thrombosis ultrasounds to rule out DVT. The patient wasn't having any tachycardia, they weren't having tachypnea, they weren't having dyspnea, and their SpO2 was 100%. So very low suspicion for a pulmonary embolism. So no CTPE was obtained, but there was worry about potentially bilateral DVTs. So they got those ultrasound, which was negative. Okay. So let's further our chest pain workup, right? Because that's the most crucial when a patient comes in with those kind of complaints. So if we look, right, we look at the forest and then the trees, right? This looks regular. If we look down at lead 2, remember lead 2 goes from right arm to left leg. So it's pointing down towards the axis in which the electrical signal travels down through my heart pathway. Let me just expand this a little bit. We look forest and then the trees. It looks very regular. Let's see if we find one that lines up. This one's pretty good. So this would be 300, 150, 100. That would be 75. It's a little more than 75. Let's call it 80 beats per minute. Is there a P before every QRS and a QRS after every P? Absolutely. Do my P's look okay in 2, 3 AVF are the big ones I look for first. Good. Yep. They don't look too wide. They don't look too tall. So I think about like 3 millimeters wide or 2.5 tall would be abnormal. 3, they look good. AVF, they look good. We look at V1. V1 can have biphasic P waves. If the negative terminal force is really big, that can key me in on left atrial enlargement. If the positive terminal force is really big, that can keep me in a right atrial enlargement. Same idea. If the P waves are really tall, that's called P pulmonale, could indicate right atrial enlargement. If the P waves are really wide or they have double humped, especially in lead 2, that could be left atrial enlargement. That's called P mitrale. My P's look good. My PR interval looks good. It looks tight. It's within 0.12 to 0.2 millimeters. So that would be 3 to 5 little boxes. Okay. So one big box is 5 little boxes. Okay. If you're new to reading EKGs. So my P waves look good. Let's look at my QRSs. They all look nice and neat, right? They usually need to be, or not usually, they need to be less than 3 little boxes to be considered narrow complex, which is what I like to see. They all look good. Let's look at how do my R waves progress from V1 to V2 all the way to V6. So boom, getting bigger. Get a little bit smaller between V5 and V6, but that's okay. We aren't seeing the full R wave progression, but in this case, we'll see, does that need to be anything I need to worry about? We can look at my axis, okay? If lead 1 is up, I look at lead 2, it's also up, so we've got a normal axis. We looked at rate, rhythm, we've looked at axis, we looked at our P waves, we've looked at our Q waves, okay? Now let's look at our ST segments, okay? Might be just slightly elevated in lead 2, okay, and it's hard on this one, but it's probably only up by 1 little box, and usually I need to see it up by 2 little boxes, so I'm really not worried about this. And if I look at lead 3, again, it's maybe 1 little box. It's very hard to really see, but it's not high enough that I'd be concerned. We'll look all the way across our other ones, all the way across our other ones, and then any ST segment depression or elevation here, nope. And then we look at our T waves, right? Are my T waves upright where they should be? They're looking pretty good so far. Yep. They're allowed to be down in AVR and they're allowed to be down in V1. So that's okay. And then let's look at our QT interval, right? So the T wave should come back down to baseline in between the halfway point or less than the halfway point between R to R. And if we're looking at our rhythm strip, it absolutely does. So my QT is within reference range. So when I look at this, right, this is normal sinus rhythm. The patient has a ventricular rate of probably about 80 beats per minute. So no ST depressions, no ST elevations, no change in troponins. So chest pain, probably not due to acute, or actually we can say not due to acute coronary syndrome. We can figure out what's going on with the chest pain in a little bit. But there's nothing we really need to do urgently because we know it's not acute coronary syndrome and we have very low suspicion of PE. Other things I need to worry about right off the bat for a patient with chest pain that comes in, right? What are the things that could kill my patient? Would be acute coronary syndrome. We've got cardiac tamponade, pulmonary embolism, pneumothorax, esophageal rupture. Those are some of the bigger ones I need to worry about. And then also I would think about aortic dissection as well, right? So those are like the big 6. So 3 kind of heart things: ACS, cardiac tamponade, aortic dissection; 2 pulmonary things, PE, pneumothorax; and then 1 GI thing, esophageal rupture. Those are things that can cause chest pain and need to be acted upon immediately. We've ruled out ACS at this point. Here we go. They got a cardiac echo, or actually I should say they got a cardiac ultrasound because they just did it in the ED really quick, and it was read as no effusion, normal cardiac function, and normal valves. Now, granted, this was just an ultrasound, but right, so we're not thinking tamponade, right? She also didn't have JVD, muffled heart sounds, hypotension. Patient is SpO2 100%, not in acute respiratory distress, probably not a pneumothorax, no history of vomiting. We don't have any kind of hemodynamic instability, no crepitus around the chest. I'm not thinking esophageal rupture. She's hemodynamically stable. She doesn't have tearing chest pain radiating to the back. I'm not thinking aortic dissection at this point. Her chest pain is likely due, it could be due to a cardiac non-ACS source. It could be another pulmonary. It could be GI. It could be musculoskeletal, or it could be like other, like anxiety or herpes zoster. I'll do a whole lecture on chest pain coming up in a little bit. We'll go into this further. But I'm not, based on everything I've seen in the ED, stable and unchanging tropes, normal sinus rhythm, EKG without any ST changes. And now we did this cardiac ultrasound with no effusions, normal cardiac function, and normal valves. I'm not too worried. Okay, we'll figure it out. We got the cardiac ultrasound also because her BNP was 814, which could signify ventricular stretch, potentially from heart failure. And this patient has this new onset swelling that we need to learn more about. So that was part of the reason we got that. But really, that cardiac ultrasound didn't show us much. So let's dive into the history a little bit more. This is a 33-year-old female, G5, P5, and she's 8 months postpartum. Previously healthy, no chronic meds or prior hospitalizations. We got, when I went in and took a history, like this is kind of the timeline that I was given by the patient. So maybe about like June 22nd, they had like fatigue and malaise. Late June, maybe had bilateral post-auricular pain radiating to the jaw. They woke up sudden with like diffuse non-pitting edema. A week later, after the fatigue started, they developed chest pressure that was worse with supine and maybe had some like muffled hearing on the left side and some numbness and tingling in the legs. And then they noticed facial swelling and skin tightness. And then ongoing, they had this history of easy bruising, gum bleeding. It was chronic. It maybe might have worsened in the past couple of days while this was all going on. So really, we've got this like fatigue malaise prodrome. We've got this post-auricular pain that radiates to the jaw bilaterally. They have this sudden diffuse non-pitting edema. They then develop chest pressure that was worse with supine and some muffled heart sound and numbness and tingling in the legs, some facial swelling and skin tightness, and then this history of the easy bruising and gum bleeding that hasn't like just, it didn't just like start, but it has maybe gotten a little bit worse. So some more like in-depth history that I was able to obtain. We've got the bilateral post-auricular pain. We've already talked about the muffled hearing, the paresthesias in the lower extremities. It was kind of symmetrical and non-dermatomal. No facial droop, no dysarthria, or no other focal deficits. Patient did not have fever, chills, urticaria, or pruritus. There's no weight loss, and actually she gained 15 pounds, likely from the fluid, really in the last couple days. No dyspnea, wheezing, abdominal pain, or diarrhea. No known drug or food allergies. She recently increased her shrimp intake, but has eaten shrimp for many years. No urticaria, like I talked about, so those are hives or wheals. No flushing or airway compromise. Family and social history. The mother has an unclear thyroid disorder. We weren't able to get anything more about that. No family history of bleeding, autoimmune, or angioedema. She did live on a farm with 11 chickens and 2 dogs. No recent travel, no big change in diet other than a new multivitamin. Does endorse eating lots of fish. Drinks natural spring water, but others in the household drink it too and they were asymptomatic, and then has an overall vegetarian diet. She has this history of the easy bruising and gum bleeding for years. It worsened recently. No heavy menses, epistaxis, GI bleeding, or hemarthrosis. No family history of bleeding disorder. Her OB history, right? G5, P5, 8 months postpartum. No prior postpartum complications. No recent hormonal contraception. Menses resumed. No Raynaud's, dysphagia, skin changes beyond edema. So thinking about all this, right? I've got a patient who's got swelling. And if we go back, right, she's kind of got this diffuse non-pitting swelling, face, arms, hands, legs. Okay, very noticeable by the patient and noticeable by the medical team as well. First thing I got to worry about, right? We worried about that chest pain right off the bat. I need to worry about, okay, this patient has like this diffuse edema. Can she breathe okay? We already know she has no dyspnea. Her SpO2 is 100%. Got to ask though, hey, has your tongue been swollen? Do you feel like you're getting tight in your throat? Because those are medical emergencies, okay? We ruled all that out. I also hear here like the skin tightness. So that made me ask about the Raynaud's, esophageal dysmotility. It made me look at her hands, right? See any sclerodactyl digital ulceration, any calcinosis cutis, all of that negative. Very reassuring against any kind of like scleroderma or sclerosis. But you got to ask. She has this easy bruising and gum bleeding. That's been going on for years. No family history of any of that though. And then we're kind of interested in, she's 8 months postpartum. Okay, could this be something here? Um, she really didn't have any travel changes. She has a new multivitamin, but multivitamins shouldn't be causing like diffuse pitting. Is something about the chickens and the dogs? Is that causing something? Should we worry about that? What about this shrimp intake or this a lot of fish in the spring water? Do I need to worry about that? Right? This is all like classic, like USMLE will put this crap in questions and you're like, holy shit, do I need to like think about this or not? Right? That's the reason they do this is because in real life, this stuff happens and you're like, do I need to consider this? You should always consider things and then try to rule them out systematically. All right. So her review of symptoms, she has this non-pitting edema and skin tightness kind of throughout her entire body. She's got the bilateral post-auricular pain radiating to the jaw and then the muffled left ears. She's got paresthesias in the lower extremities, no murmur or friction rubs, clear and no crackles heard on lung exam. So I want you to think about what are the broad bucket things we should be thinking about when we see a patient with non-pitting edema. So we often think about pitting edema, but what about non-pitting edema? How should I think about non-pitting edema? So pause your screen and think about it. So for non-pitting edema, we think about proteinaceous, inflammatory, lymphedema, or mucopolysaccharides that are in the interstitium. Okay, so the way I think about it is it gives the interstitium some sort of scaffolding. Okay, and it pulls fluid with it, but it's like it's scaffold, right? We've got like actual materials in the interstitium, so I can't press down. If it were just to be fluid that's moving into the interstitium and none of this proteinaceous mucopolysaccharide type materials, and I push down, well, now it's just fluid. I'm actually going to indent the skin. But when I have all this material with the fluid, it makes it very hard for me to press down and actually see any pitting. Okay, so broad buckets, I think about, okay, protein is moving into the interstitium with the fluid. Maybe we have some sort of lymphedema, right? The lymphatic system is really important to remove some of these proteins from the interstitium. So maybe is there some sort of lymphatic obstruction? We think about inflammatory processes that make my capillaries really leaky. So fluid and protein can leak out. Or we think about mucopolysaccharides like glycosaminoglycans, okay, that can leak out. And we'll talk about all this in a second. So when I think about broad buckets, what are the three general mechanisms of edema, right? So we talked about what should I be thinking about if my patient has non-pitting edema? Okay, what are my just general buckets for edema? How do I think about edema? Well, when I think about edema, right, we can really think about it as an increase in hydrostatic pressure, a change in oncotic pressure, or increased permeability. And when I think about oncotic pressure, it could either be a decrease in capillary pressure or an increase in interstitial oncotic pressure, right? And so here are some the classic things, right? So when I walked into this patient's room and I had this long conversation with her, I sat down for 45 minutes to like an hour and really had this conversation because this was a pretty significant problem, right? Had been to urgent care, had been to the emergency department, no answers. We got to figure this out, right? Because this could be something serious, or it could happen again, or this could be, related to something she and her families are exposed to. So we got to figure it out. But when I walked into a room, I went in with these general buckets and these general things I wanted to slowly rule out, right? Some of them we can only do really via, imaging in labs, but some of them we can rule out just by history alone, right? So when I think about increased heart failure or increased hydrostatic pressure, and I think about heart failure, hey, do you have any orthopnea or paroxysmal nocturnal dyspnea? Obviously, I'm not going to say that to the patient, right? You would say, hey, when you lie down, does it feel like it's hard to breathe? No. Okay. Maybe she had some chest tightness when she was lie down, right? She told us about that. But she doesn't have orthopnea. She doesn't feel like she's struggling to breathe in the middle of the night. So her BNP was elevated. We got that ultrasound that was pretty normal. I might still want to get a TTE, especially because she's postpartum. Could this be postpartum cardiomyopathy? Let me get better imaging, right? Renal failure, right? We'll talk about her labs, but really, she's a young, healthy 33-year-old, not worried. Cirrhosis, she had no stigmata of chronic liver disease, right? No pulmonary erythema. She didn't have any telangiectasias, right? No ascites. And then we'll look at her liver lab soon. Deep vein thrombosis, we already ruled out. Venous insufficiency, it'd be really rare to have venous insufficiency all throughout, like cause like problems all throughout your body. She's also 33. I didn't notice any venous insufficiency or any medial malleoli ulcers. Less likely. Pregnancy, she obviously was pregnant. She's not currently pregnant. Not likely. Medication, she doesn't take any medications. She did have the new multivitamin, but again, would be very, very, very low suspicion. I took a look at all the ingredients. Nothing that could really explain this. Superior vena cava syndrome could be considered, right? But that's when the superior vena cava is obstructed. But it would lead to really like facial plethora. My JVDs would be elevated on both sides, but it would be kind of confined to the face, not to the whole body. Same with like IVC obstruction, right? If the IVC was obstructed, we'd think about it as, the bottom half of my body being all edematous, right? But not really maybe the upper arms or the face. She was edematous all over. And then constricted pericarditis. Again, the heart can't really expand. Fluid backs up and can cause edema. We got that cardiac ultrasound and the ED didn't show any effusions. When I think about oncotic pressure, right, decreased capillary, again, we've already talked about liver disease. Malnutrition sheets, a pretty good diet, definitely did not appear malnourished. Nephrotic syndrome, we'll get a UA on this patient for sure. We'll talk about that. Protein losing enteropathy, right? So if you're losing protein through malabsorption and through diarrhea, we could consider that. The best way to test for that is getting alpha-1 antitrypsin levels in the stool. Patient has no history of any malabsorption, no diarrhea, doesn't feel like her she doesn't really have any GI symptoms. Was very low suspicion for that one. Increased interstitial. Hey, we've talked about lymphedema and mixed edema. These seem kind of intriguing, right? Because they could cause non-pitting edema, right? So if the lymph gets obstructed, we get extra protein in the interstitium and it can cause pitting. But would a patient just wake up kind of one morning and just have diffuse non-pitting edema from lymphatic obstruction, right? That would be kind of rare, right? Usually you have lymph obstruction in one spot, not throughout your entire body. And then mixed edema, right? So mixed edema are mucopolysaccharides or glycosaminoglycans that deposit into the interstitium and can draw fluid in, right? So we'd want to get a TSH on this patient, which we did, and I'll show you. And especially, hey, that mom has a thyroid disorder, right? Maybe it's kind of intriguing. And then we think about increased permeability, right? So any kind of local inflammation, right? So any kind of cytokine release can make my vessels leaky, right? When I look back at her vital signs, she was totally afebrile. She really was hemodynamically stable. I didn't see anything on chest x-ray that would give me, any kind of pneumonia. We'll get a UA on this patient in a second, maybe a UTI. Does she have anything going on? I don't know. We'll have to see, right? But any kind of inflammatory process could kind of be smoldering underneath the surface here and could be causing local inflammation. So we got to keep it in mind. Preeclampsia, hey, wait, the patient was just pregnant, right, 8 months ago. Could this be preeclampsia? Well, usually we define preeclampsia as stopping about 6 weeks after postpartum or after birth. So we're not considering preeclampsia. Angioedema. Angioedema is a very, very intriguing option here, right? She has the full body swelling, right? That just kind of happened, especially of the face and the lips. She even mentioned, right? So any kind of facial swelling, right? So I'm keeping that one in my back pocket. This idiopathic edema, I hate idiopathic diagnoses because there's always an explanation, right? But idiopathic, we don't have an explanation for it. If you look in the literature, this idiopathic edema is classically described in post-pubertal but premenopausal women. So she definitely fits that. The thing with idiopathic edema is it's usually this recurrent edema that progresses throughout the day. And then maybe the patient goes to bed and then they wake up again with it again. And it just kind of keeps coming. This didn't really fit her story. This is the first time it's ever happened to her. And it was just kind of continued to progress. And this idiopathic edema usually changes with position. And the patient noticed that really when she was changing positions, raising her legs, that wasn't totally helping. And then there's this intriguing capillary leak syndrome, which is a whole spectrum of diseases. There's on the bad side of the spectrum is called Clarkson's syndrome. Clarkson's syndrome is a medical emergency. It's a combination of this diffuse edema, hemoconcentration because we're losing all the fluid. So all my cell lines are hemoconcentrated, and then hypoalbuminemia, right? The patients are essentially in hypovolemic shock. They usually require the ICU. Do you think this patient fits Clarkson syndrome? No. But the patient could have had some sort of local inflammation that then led to diffuse capillary leak, right? So kept on my differential, right? And we'll talk about it, okay? So that's kind of how I went in thinking about everything, right? I usually when I have a patient with a new chief complaint, if I have the time, I like drawing this out on a sheet of paper and I literally go into their room. And as I'm having the conversation with the patient, I will ask more guided, directed questions, and I can just cross out or circle things that I think might be more reasonable and cross out things that I think are not as reasonable. So that's what I did here. Um, so some more labs that we wanted to get, right? Her BUN was still low, her creatinine was still low, likely due to hemodilution, right? So this again would point away from like true Clarkson's. But when I see really low BUN and creatinine, maybe we've got like a fluid redistribution, so the fluid's moving out and then in, and then out and then in. Same idea with the BNP. Okay, so she's got some stretch on her ventricles, okay, but her lung sounds were clear. And we'll take a look at the cardiac echo in a second. But we're really not thinking it's heart failure. So again, maybe fluid moving out and then quickly moving back in, stretching the ventricles, and then the fluid moving back out again, potentially, because that's slightly that's like in line with some of these like angioedema, capillary leak syndrome, where the vessels get really leaky. We kind of get just fluid redistribution into the interstitium back, into the interstitium back. Um, Her albumin and total protein, her albumin on admission was 4.1. It did drop to 3.4, again, just slightly low. Her total protein was 6, and then again, dropped to 5.6, slightly low. So relative intravascular depletion, maybe. CBC on admission was hemoglobin of 10.4, and it was normocytic. Um, Platelets, started like I look back in the chart, the platelets had always been normal. Her platelets on like the first blood draw were 146. Like she has this history of like gum bleeding and easy bruising. But then they bounced right back up to 193. Her MPV was elevated on that 146. When the MPV is elevated, the mean platelet volume, that tells me there's more megakaryocytes in the circulation. So maybe was she having like a mild consumptive process? But the fact that the platelets bounced right back up, I wasn't even worried about it. And then we got a CRP, ESR, and ANA, all within normal limit, not consistent with active systemic inflammation. We got an echo. Her left ventricular ejection fraction was 51% with mild global dysfunction. We did consult cardio, and they were not worried about this at all. They said it did not qualify as any kind of heart failure. So we were not going down the heart failure route. And again, when you think about like heart failure and increased hydrostatic pressure, it really wouldn't cause the kind of picture we saw first. Like heart failure is usually going to be more pitting edema because there's not that proteinaceous mucopolysaccharide type material. And really like the facial edema was quite weird too. Okay. The CT angio, we got a CT angio just to look at, some of her her like vessels, just to make sure those weren't obstructed, all normal. So my teaching pearl here is like the BNP can be elevated in capillary leak syndrome due to myocardial stretch, even with preserved ejection fraction, because the fluid's moving out and in and out and in. And when it moves in, it can quickly overwhelm the ventricles and we get stretched, the BNP gets elevated, and then as the fluid's moving back through the system, it makes its way back to the leaky vessels and moves back out. Okay. I don't think I put it on this slide, but we did also get a von Willebrand factor panel, just because with this history of easy bruising and gum bleeding, and that actually came back normal too. So maybe this patient is just predisposed to easy bruising. You could do further workup for things like Bernard-Soulier or Glanzmann thrombocythemia, outpatient, like if she followed with a hematologist. But that wasn't really her major concern, right? This is why you have to like consider, okay, is this bleeding and this bruising and gum bleeding, is that related to her underlying swelling? Like I don't think so, right? We crossed our T's, dotted our I's just to make sure. But it really didn't, our workup came back with really nothing. She'd probably need a more hematological workup if she wanted answers on that. But I don't think I put the von Willebrand anywhere. So we wanted to get that was like our initial. And then after I talked with her, I'm like, I have a very strong suspicion on this capillary leak and then our angioedemas, right? There's a couple different types of angioedemas. So I want to get more information to see if I can rule in, rule out those. Problem with capillary leak syndrome is there aren't really tests we can run for that. That's more of a diagnosis of exclusion. Angioedema, there are tests, but they're send out tests, so it takes a little bit. So this is what we did. I got a C4, a C1 esterase inhibitor, a C1 esterase inhibitor function, a C1Q. We got a factor VIII, an SPEP, UPEP immunofixation, serum tryptase, viral panels, a UA and urine protein creatinine ratio, and then ANA, SSA, SSB, HIV, HEP panel. We actually got syphilis too. So some of these still pending. So we'll follow out outpatient with their, or they'll follow up outpatient with the PCP. But reasoning, right? C4 was normal, and we'll talk about this in a second. The esterase inhibitors are pending. The C1Q pending. Factor VIII was elevated. Remember, factor VIII, I talked about this in my liver disease versus DIC lecture. Factor VIII is the only clotting factor not made in the liver. It's made from endothelial cells. So when you see the activity is elevated, that tells me there's endothelial stress. Hey, ding, 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 capillary permeability. So I'm going back to my, schema, and I'm thinking now again more about my capillary permeability. I don't think I put on here, but her TSH again was normal. We already knew it was normal at the urgent care. It wasn't like it was probably going to change in 2 days, but we got another one just to make sure. So less likely mixed edema, especially like the patient would have to have pretty poorly controlled hypothyroidism to get that type of diffuse non-pitting edema. We got an SPEP, UPEP immunofixation, which I'll talk about why in a second. Still pending. We got a serum tryptase. Tryptase, it tells me like histamine release, right? Or like mast cell activation, right? So tryptase is released from mast cells. Now, granted, this patient didn't have any pruritus or urticaria, but the reason I wanted to get this is because we have to rule out things like systemic mastocytosis and other kind of histamine-related diseases in order to get to our final diagnosis, because some of these are diagnoses of exclusion, so we got to rule out mimickers. So that's why I ordered that. I wanted to get a viral panel on this lady because she told me about this week of fatigue and malaise and this bilateral posterior auricular pain. I felt no lymph nodes, but could these have been like small inflamed lymph nodes that she's feeling? Potentially. Could the fatigue and malaise be potentially explained by a virus? Maybe. Could the virus have then caused endothelial dysfunction? That's why I ordered these specific viral panels, because EBV, CMV, Parvo, COVID, and HHV6 have all been described in the literature to cause endothelial dysfunction. Now, these are very low yield tests because, hey, maybe we find something, maybe we don't. It's not going to change management, but maybe it helps us get a little bit better of a picture of the story so we can tell a better story. And actually, if it's a viral trigger, we can then tell the patient, hey, this might have been just a one-off viral trigger causing your vessels to be leaky, and so you should be okay. If the viruses come back negative, again, diagnosis of exclusion, we can get closer to our end goal. We got a UA and urine protein creatinine ratio, which is normal, so no nephrotic syndrome here, right? We'd have to see protein greater than 3.5 milligrams, 3.5 grams over 24 hours. So definitely no proteinuria at all on the UA, so we didn't even need to do a 24-hour urine sample. And we got the urine protein creatinine ratio, which is more of like a spot dose, and again, nothing. All of her HIV, Hep B, Hep C, syphilis, all negative. The ANA, SSA, SSB, negative. So really, the C4 being normal, and then we're waiting on the esterase inhibitors and the C1Q, which will really tell us a lot. And I'm going to explain why I got those tests in a minute. And then my next question for you is, why did I order the SPEP and the UPEP with immunofixation? Okay, so I've kind of explained the other tests I ordered, a lot of them being like crossing out, removing things from my list, right? We've ruled out rheumatological, we've ruled out nephrotic. We got a serum tryptase, which we haven't gotten back yet, but we're very low suspicion for any mast cell disorder. The factor VIII, we got more for like the working up of her bleeding cause, but we actually saw it was elevated, which actually points more towards an endothelial dysfunction. So why did I get the SPEP UPEP with immunofixation? What's the deal there? So I ordered this because in capillary leak syndrome, especially Clarkson, which remember is like the severe end of the disorder, it's strongly associated with monoclonal gammopathy, often that IgG kappa type. And studies show that up to 90% of patients with the systemic capillary leak syndrome have an underlying plasma cell dyscrasia, even if they're asymptomatic. So the reason we got this is to detect any monoclonal protein that may have caused, that may not cause hyperviscosity or a gamma gap, right? So gamma gap is when my total protein to albumin, if I take the total protein and I subtract the albumin, if that's greater than, usually literature says 4.4, that's considered a gamma gap. That tells me there's an extra protein somewhere in my body that's elevating the total protein level. But that elevated monoclonal protein can still contribute to the endothelial dysfunction, even without causing hyperviscosity or the gamma gap. So she had normal labs. We didn't see any symptoms of hyperviscosity. She did have the paresthesias. We're thinking the paresthesias were more from the skin stretching. Same with the chest pain. She came in with that chest pain, probably from the skin around her chest, stretching from the extra fluid. But the monoclonal protein could still be causing some of these problems. So my teaching pearl is even in mild or subclinical M proteins, they can cause cytokine-mediated vascular instability and cause a CLS spectrum disease. So if the ASPEP UPEP with immunofixation comes back abnormal, hey, maybe that points us more towards systemic capillary leak syndrome, right? Or capillary leak syndrome. If it comes back normal, maybe it points us more in the other direction, right? Of other capillary permeability problems. So that's the reason we got that test. So I want you to think now, I've given you a whole lot of information. What would be your top 3 differential? Okay, so think about those. So really, we've ruled out cardiac, right? Pericarditis, low likelihood. The reason I brought it up, right? She had maybe some chest pain when lying down. And so that tells me, right, the normal pericarditis is, hey, it feels better when I lean forward. Well, you can think about it opposite, right? If the patient lies down, the pericardium is getting squished and it can lead it to cause pain. We didn't see any fever. The patient really didn't have any other symptoms of like pleuritic chest pain. And we got a pericardial echo, and we got an echo and a cardiac ultrasound that didn't show any effusion. I have a low suspicion of pericarditis. She had she was postpartum, but it was ruled out. The postpartum cardiomyopathy was ruled out by echo. We also usually see postpartum cardiomyopathy within the first 5 months of pregnancy. She was 8 months out, or within the first 5 months postpartum. She was 8 months out, so less likely. GI, she didn't really have any symptoms of malabsorption, so no suspicion for protein losing enteropathy. Renal, we ruled out nephrotic syndrome. Hepatic, we ruled out cirrhosis. Endocrine, we ruled out mixed edema. Infectious and immune, we really ruled out early autoimmune based on her labs and presentation. So really, we're thinking more of the vascular permeability, maybe postpartum capillary leak, right? She's quite far out. Could be CLS spectrum disorder, could be a non-histaminergic angioedema. Because remember, the patient didn't have any urticaria or flushing or any of those kind of histamine type symptoms, and she was given Benadryl and had no response, right? So it'd probably have to be a non-histamine mediated. It could be post-viral endothelial dysfunction, kind of fits with the fatigue and then the post-auricular pain and now this edema, or it could be that idiopathic edema, okay? So our problem description, let's put it all together, clues towards a vascular permeability disorder, right? So we went back here. Why am I leaning towards this vascular permeability? We're seeing a sudden onset non-pitting edema. We see facial involvement. We see an elevated BNP and factor VIII. We see no pure proteinuria or heart failure. No improvement with steroids or Benadryl. So the top working diagnosis could be postpartum capillary leak physiology, CLS, capillary leak syndrome spectrum disorder, or a non-histaminergic angioedema. And those are usually driven by bradykinin. Okay, so is the key this viral trigger, right? The timeline suggests the fatigue and then the ear symptoms and then the edema. That really raised my concern for a viral endothelitis, right? So some sort of inflammation of the vessels that could cause leakiness, right? That's why we got these some of these viral tests. Again, idiopathic edema was considered as it's classically seen in premenopausal women, but it usually is reoccurring and related to position, which was not consistent with this patient's presentation. And I don't like putting the label of idiopathic on anything. So how do we manage the patient in the hospital? We gave fluid restriction. We did compression stockings. We gave some IV Lasix. She got a lot of fluid off. We didn't do steroids or antihistamines because she actually didn't do well on them and actually might have gotten a little bit worse. She said they made her feel pretty bad. We held her venous thromboembolism prophylaxis because she had this history of bleeding concern. The workup underway. We've got the tryptase, we've got the SPEP, UPEP, immunofixation, C1Q, C1INH function and level. We've got the viral serologies pending. So my pearl for you, right? Idiopathic non-histaminergic angioedema is a diagnosis of exclusion. That's why I had to order some of these tests that I knew would come back negative just to rule other things out so we can make a final diagnosis. It often requires empiric therapeutic trial with bradykinin blockers. Okay, so my takeaway for you guys, sudden onset edema without heart failure, nephrotic syndrome, or cirrhosis. I want you to think about a vascular leak. Non-pitting edema, you want to think about protein or inflammatory mediated. Angioedema doesn't always respond to Benadryl or steroids because it may be driven by bradykinin. The postpartum state is a high-risk window for immune and vascular dysregulation. And the BNP can be elevated without heart failure in capillary leak syndrome due to volume redistribution. So all really important things. So I have a few more follow-up questions and then we'll tidy it up. So what distinguishes histaminergic versus non-histaminergic angioedema? Why is C1 inhibitor function more useful than just levels? What are the clues to early mild capillary leak syndrome? Would you start a trial of bradykinin blockade on this patient right away? And would you send her home if she improves, or does she need close follow-up? So pause your screen and think about these 5 questions and then we'll discuss. So the histamine versus non-histamine angioedema, when I think about histaminergic, it's rapid onset, okay? It often is associated with the hives, the itchiness, and an allergic trigger. It responds to antihistamine, steroids, and epinephrine. Not really fitting this patient, okay? The non-histamine or the bradykinin mediated, slower onset, no hives or itchiness. It's often refractory to antihistamines or steroids. It does have facial, tongue, GI, or airway involvement. It can be hereditary, or it could be acquired, or it could be idiopathic. That fits more of the story this patient had. C1 inhibitor function is more useful than just levels because some patients may have normal C1 inhibitor quantity but reduced activity. So when they have reduced activity and normal levels, that's called type 2 hereditary angioedema. Yeah, I bet you didn't know there's multiple types. So that's something very important. I'll show you a table coming up. Functional assay captures whether the C1 inhibitor is working, not just present, right? And it's needed to detect bradykinin-mediated angioedema, okay? So the C1 inhibitor function identifies type 2 hereditary angioedema from acquired forms missed by if we just got the total protein amount, okay? So my key takeaway, if you suspect any patient might have angioedema, we need to get C1 inhibitor function and levels, right? What are the clues to early mild capillary leak syndrome? Sudden onset non-pitting edema with no proteinuria, heart failure, or liver disease. Low to normal albumin, but no nephrotic range losses. Elevated BNP without cardiac dysfunction can be seen. Hemoconcentration, a low BUN to creatinine ratio, mild thrombocytopenia, often post-viral or postpartum, and fatigue malaise may precede vascular symptoms. Again, pretty in line with everything we saw. The patient didn't have hemoconcentration, but everything else kind of in line, right? So definitely thinking maybe could be an angioedema type picture or capillary leak syndrome. Would we start bradykinin blockade if there's a high suspicion for non-histaminergic angioedema? We could consider a trial of icatibant, which is a bradykinin B2 receptor antagonist, or there is C1 inhibitor concentrate. In idiopathic cases, giving the patient one of these can actually be diagnostic and therapeutic. We as internal medicine would not do this. You'd have to probably talk to allergy immunology. But that's something they could potentially do outpatient. Would you send her home? Yes, with close outpatient follow-up. We can arrange allergy immunology referral, complete the pending tests, emergency returns if she has airway or facial swelling. We can consider that short inpatient observation, which we did, and then an outpatient trial of the targeted therapy potentially. So the different types of angioedema. So type 1 is the most common. That's the one you learn about in med school, where there's a low levels of C1 esterase inhibitor, the C1INH. So the mechanism, there's low C1 esterase inhibitor leads to elevated kallikrein, which leads to elevated bradykinin, and bradykinin is what makes the vascular permeability all throughout your body, okay? Leaky vessels. So in the key lab findings, we'll see low levels of C1 inhibitor and low levels of C4. Remember, our patient's C4 actually came back right away and it was normal. We can think in type 2, it's dysfunctional C1 inhibitor. It's got normal quantity, but it doesn't work. So it's the same pathway where C1-INH has normal levels, but it just doesn't work. So the bradykinin builds up. So we get normal or elevated C1 inhibitor, but decreased function and decreased C4. And then there's type 3, which is rare, but it's mostly in women, okay? It's a factor 12 gain of function mutation, and the C1 inhibitor is normal. So there's an increased function of factor 12, which leads to increased kallikrein, which again leads to increased bradykinin and increased angioedema. And in this one, every single lab, the C4, C1 inhibitor function and level are all normal. So this would be a diagnosis of exclusion. In factor 12 levels are not reliable to make this diagnosis. You actually have to do genetic testing to find the genetic mutation. So my overarching theme here is all types of hereditary angioedema cause bradykinin overproduction, which increases vascular permeability, leading to non-pitting, non-pruritic angioedema that does usually not respond to antihistamines or steroids, okay? Sometimes they can, if it's histamine mediated at its core, but if it's bradykinin mediated, they may not respond fully to the Benadryl or to the steroids or any kind of antihistamines, okay? Because it's not histamine mediated, okay? So the last lab we haven't talked about is the C1Q, which I ordered on our patient. Why would we check that? The C1Q can help differentiate hereditary from acquired angioedema. So hereditary angioedema, the C1Q levels are normal, but in acquired angioedema, the C1Q levels are low. So low C1Q, it represents classical complement consumption via immune complexes. So remember, C1Q is in my classical pathway, classical complement pathway. So if my C1Q levels are low, that means the C1Q is being used up. And that's usually a reflection of increased complement production. And that increased complement production is being used to make immune complexes, secondary to some sort of autoimmune disease or some sort of cancer. Okay? So what do I have for you? Here's my final clinical impression. Again, the patient will follow up outpatient. I'll follow the labs just so I can get an answer. And hopefully she can get an answer too. But I'm thinking this is either idiopathic non-histaminergic angioedema, potentially type 2 or type 3. It's probably likely got to be type 3 because C4 came back normal, okay? Granted, we didn't catch her in like an acute bout where she had this. So maybe the C4 normalized, or this could be mild postpartum capillary leak physiology, likely triggered by viral immune response. So the proposed mechanism I came up with that I presented to our team was probably a post-viral immune dysregulation. She had the fatigue, the auricular pain, the edema. It was triggered this transient endothelial dysfunction. It led to increased vascular permeability without that protein loss. She had the redistribution of fluid, non-pitting edema, facial swelling, the BNP elevation. There might be an overlap with the bradykinin-mediated angioedema. She didn't have hives. She didn't have pruritus. She had no response to antihistamines. She did have a normal C4, and we're pending the full complement. So again, if you look back here, usually C4 is low in type 1, type 2, but it could be normal in type 3. I think this likely could have been some sort of post-viral capillary leak. I don't think we can totally rule out angioedema at this case. I think it makes a very intriguing option as well. That's why I wanted her to follow up with allergy and immune. But okay, so this was a very in-depth clinical reasoning session. This is like the massive slide you have to understand. Hydrostatic, oncotic, capillary permeability. Oncotic I can break down further into decreased capillary and increased interstitial. All very important. When you think about a very complex patient, we have to break it down into its like itty bitty pieces and think about each piece individually, right? How does each piece individually play out, and then can you put together a beautiful story, kind of how I did at the end, right? Do the labs and the imaging and the clinical picture support that story? If not, change the story, right? And that's the cool thing about medicine is as we get more data, the story changes, right? Never anchor to anything. as the more data comes in, we can change that story around to potentially get that diagnosis and help the patient out. So I hope this clinical reasoning session was useful. Please reach out. I didn't put it on here, but you guys all know my email. Reach out if you have any questions, and I'll keep these clinical reasoning sessions coming along with the normal lectures. All right, until next time.